The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Welcome to Your Health, Your Choice. We are doing another one of our pre-recorded programs, so you'll be looking at this program on Wednesday night or Thursday afternoon or Sunday evenings at 7 p.m. Unfortunately, you'll not be able to call in to the program, but we will give you numbers later on where you can call in for your questions. Your Health, Your Choice. What is this all about? This program is all about empowering you to make the right decisions about your health. The last program we did, we talked about diabetes again, and we came back to the one of my, well, it's my specialty area, and we got a lot of good feedback. I showed you some new devices, new ways of giving insulin. Today, we're talking about the causes of type 2 diabetes. Now, I want to say very quickly, when I say causes, I'm not going to talk so much about lifestyle, etc. We're going to look at what we call the pathophysiology of type 2 diabetes. What's happening inside the body that drives diabetes? Because very often we reduce the cause of diabetes to lifestyle, that people are eating too much, they're not exercising, etc. But actually, the causes of type 2 diabetes is much more complex than we think. And the American Diabetic Association and the European Association for the Study of Diabetes have been constantly updating their guidelines. And I'm going to ask Josh to bring up slide 5, and just demonstrates what we talk about. When I say a new approach, it's called a patient-centered approach to diabetes. And it's very interesting. If you look at the statement there, it's providing care that is respectful, responsive to the individual patient preferences, needs, and values, ensuring that the patient values guide all clinical decisions. And later on, you will see underlined there shared decision-making, a shared decision-making process. So we can just come off that slide and talk about that for a second. So what we are seeing here is that the treatment of diabetes is not doctor-centered. And I know we still have a top-down approach to doing medicine in this country. And that's why I sometimes advise some of our young doctors to go abroad for a few years as they specialize, because it opens you up to a new approach, or the approach that we should be using, not just to treat diabetes, but many other chronic diseases. Now, let me just say there's a difference between what we call an acute disease. If you have crushing chest pains, if you have an acute bleed, you may have no choice in the treatment because you have to agree, but you have to go into the hospital and be treated very quickly. Now, when you have a chronic disease like diabetes, hypertension, high cholesterol, asthma, these are called chronic diseases. There's a dialogue that should happen between the patient and doctor. It's shared decision-making. And very often within the government service, and I work in some of the health centers, we are more rushed, shorter consultation periods. And a lot of patients complain that they come into the doctor's office and as they sit, prescriptions are being written. Well, we simply cannot do chronic disease management like that. We need to be able to have a collaborative process with our patients. We need to take their thoughts and decisions, how they're thinking, because the fact is a lot of our patients, a lot of you're looking at us tonight, you're getting information from us, but you're also going onto internet, you're going and looking up new drugs, etc. So as doctors and as healthcare professionals, we cannot dismiss what you're presenting to us. But what we must do is practice medicine on a scientific basis. And this second slide, slide 7, it's a little bit complex, slide 7, but what it shows is the impact of intensive therapy for diabetes. What we call intensive therapy is therapy that is trying to lower your blood sugars And if you look at the extreme left, you see that there are various trials done in the diabetes research world. There's the UKPDS and DCCT from the 1990s. Then there's the Accord and Advance and VADT from 2000 to 2010. And what is not on this slide are things like the EMPA-REG, LEADER trial, etc. The green arrows show that there's benefit. The red arrow shows that we have a little bit of a problem. I'll explain that. And the yellow arrows show a neutral response. So we can just come off that slide for a minute and let me explain what that is all about. So when you looked at that slide, it showed that all those trials demonstrated if we bring your blood sugars down aggressively, it will protect you from what we call microvascular complications of diabetes. What do I mean by microvascular complications? We mean that in diabetes, the small blood vessels are affected, and you can have the blood vessels to the eye being affected, and you have what is called diabetic retinopathy. You can have the blood vessels to the kidney being affected. You have diabetic nephropathy, and then the blood vessels to the nerve ends can be affected, and you have diabetic neuropathy. So those are called microvascular complications. And there's absolutely no doubt that the better we get your blood sugars controlled and blood pressure, let me say, that you have a decreased outcome in terms of the possibility of developing all these complications, which are called microvascular. Where you saw the yellow lines, it's where we are still doubtful whether lowering your blood sugar aggressively will give you benefits, where heart attacks, strokes, that is called macrovascular complications. Macro meaning the big blood vessels, the blood vessels to the heart, the blood vessels to the brain, and the blood vessels to the leg. But let me say that the slide did not show some of the latest data. Some of the newest trials we have, one called EMPA-REG, which is with a new class of drugs called the SGLT2 inhibitors, the LEADER trial with liraglutide, which is the GLP-1 agonist, gives us now clear evidence that we have newer classes of drugs that can give you protection for your heart, for the brain, etc. So the science of diabetes is rapidly developing. And I emphasize this because when we talk about diabetes, you know, patients often come in and ask me, Dr. Khan, what do you think about Omega XL? What do you think about some of the herbal product? And I have to respond by saying, I don't know. And sometimes patients look at me a little bit surprised when I say I don't know. The reason I don't know is that we do not practice medicine on the basis of anecdotal evidence. What do I mean by that? If I give a patient a tablet with water on injection, and it's suggested that this will make you feel better, it's called the placebo effect. Remember that word, placebo effect. The mind, the brain has a very powerful healing effect on the body. And therefore, someone may feel better. They come onto one of these programs, people are paying thousands of dollars to advertise their products, and you're being told that if you do take colon cleansing, if you put your foot in some water that goes brown, you'll be detoxed. Can I say that that is almost fake medicine in terms of the science? I am not saying that all herbs are bad. There's certainly some good emerging evidence that there's some herbal products that can give you benefits. But when we talk about science, the way we should practice medicine, the way we train our medical students, postgraduate fellows, is in scientific medicine. So I need for you to understand that very clearly. Slide 8 gives you a little bit of a background on the pathogenesis of type 2 diabetes. You see that you have what is called an insulin secretory dysfunction. Simply, the pancreas is not producing enough insulin. Insulin resistance, I'll explain that. Increase endogenous glucose production. The liver is producing glucose. I'm going to talk about the incretin effect and deranged adipocyte biology. So all of those are some big terms, but it simply shows you how complex type 2 diabetes is. It's not just about what you're eating, because you can take two people. I often ask patients come into my office, and I do their blood sugar readings, and the blood sugar is 300, 350. And they say, oh, doc, it's because I had a doubles. I don't know why patients insist on eating a doubles before they come to our offices, but maybe it's just to test us out. So they may have had a doubles, or they may have had a roti just before coming to our office. And they said, doc, my blood sugar was 110 this morning, and now it's 350. I don't understand. Well, that is why we tell patients it is not good enough if you're diabetic just to do a blood sugar reading first thing in the morning. You need to do a blood sugar reading 2 hours after, particularly your biggest meal, because that is when you see how your pancreas is responding to the food you eat. So you can take two people, one who is not diabetic, the other one is diabetic, and you give them the same thing to eat, and 2 hours after, the person who is not diabetic will have a normal blood sugar, which is 80 to 90, and the other person will have a blood sugar of 300 or even 400. Why? Not just because of what you had to eat. It's how your body responded. So the point we're making today is that diabetes is not just about lifestyle. It begins with the lifestyle, type 2 diabetes I'm talking about, but it's what is happening to your liver, what is happening to your pancreas, what is happening within the GI tract. And that's where I'm going to bring up slide 9. And this is a very, very complex diagram. This is called the ominous octet. Now, I'm just going to leave that there for a few seconds. It's called the ominous octet. And this was introduced in 2008, around 2008, when we were introduced to this whole idea that it's not just the pancreas. So before we go to our first break, let's just look at the top of the diagram, the pancreas. That organ at the top there is the pancreas. So we can just come off that slide. So the pancreas, that is the first organ that we are all familiar with. The pancreas lies just behind the stomach. And sometimes, people who have pancreatitis, which is inflammation of the pancreas, can have severe pain and discomfort in that area. But very often in type 2 diabetes or even type 1, you have no symptoms from the pancreas. What happens is that the blood sugars begin to rise. Now, the rising of the blood sugar does not happen overnight. So we tell people, especially with type 2 diabetes, although it applies to a certain extent to type 1, that your diabetes did not happen overnight. So people with a family history, it's similar next week, hopefully we'll have Dr. Yadish Singh with us talking about colon cancer. These things do not happen overnight. With diabetes, you go through a pre-diabetic phase. So this is where we are trying to explain to patients that with the pancreas, the beta cells have been under stress for a number of years. And especially if you have a family history, the beta cells begin to decay, deteriorate, and then eventually you have diabetes coming on when the beta cells cannot produce enough insulin. Now, if you go in a clockwise direction, the brain, now that's a surprising organ. Very few people would think that the brain has anything to do with type 2 diabetes. But actually, we now know that there are neurotransmitters in the brain that are altered, and you have sometimes what we call amyloid deposits in the hippocampal area of the brain, the appetite-seeking centers. So there are alterations in the brain. Now, a lot of diabetic patients come in and tell us they're hungry all the time. And, as healthcare professionals or even as family members, we tell our patients that they're greedy. Typical Trinidad parlance, that they're eating too much. Now, apart from the food being very appetizing here in Trinidad, some of our diabetic patients do not always choose to overeat. What happens is that the appetite-seeking centers are altered, and therefore the perception of hunger is changed. That shows how complex this disease is, and that's why some of the newer classes of drugs we have, it's actually the GLP-1 agonists, for example, they have an effect on the appetite-seeking centers, and they allow people to be filled. Satiety is increased, so you feel filled earlier in the meal, and your appetite-seeking behavior is changed. If you go clockwise again, the third, you see that's muscle and fat. Now, I want to spend just a minute or two on that. So that's a third. We're going in a clockwise. We started at the top with the pancreas, then the brain in a clockwise direction, and now the muscle and the fat tissue. So what does this, how does this interplay with diabetes? Well, in the early days, we knew about the pancreas, the beta cells not producing enough insulin, but now we know that the muscle and the fat cells that is supposed to take the sugar out of the blood, it is resistant to the insulin that you're producing. This is called insulin resistance. And in fact, most diabetologists will now tell you that the precursor to the pancreas deteriorating is what we call insulin resistance. So long before you have the beta cells beginning to deteriorate, you have what is called insulin resistance. Now, if you have resistance to anything, what happens? The organ is having to work over time. So up to 10 years before you develop diabetes, your beta cells begin to work at a higher rate. It's becoming exhausted. And the first blood sugar reading that begins to become abnormal is the 2-hour after meal reading, or what we call the postprandial reading. Therefore, doing a fasting blood sugar to diagnose diabetes is not enough, because very often in the early stages of diabetes and prediabetes, the fasting blood sugar is normal, but the 2-hour after meal reading is high. Now, I think we have to go to a break. So when we come back, I will begin to show you some clips on the ways we treat diabetes. So we're going to go to our first break, and then we'll return to Your Health, Your Choice.
Hey, listen, we have some great news for you, our loyal viewers. No, we love to interact with you on a daily basis. So sometimes do it via telephone, otherwise Facebook. But now we've added our new WhatsApp phone number. That's right. You can now text us live on our various programs right here on ACT and The Voice at 360-0105. That's 360-0105. Send us your comments, send us your questions, and get this even better. After the lights come off, you can continue sending your comments and your questions, and we'll respond to them the following day. So that's right here on ACT and The Voice, we have now opened up more mediums for you to interact with us. Facebook, telephone call, and now you can WhatsApp your comments and questions right here on ACT and The Voice.
Kids Classic TV on ACT and The Voice.
You ding-dong! You're supposed to be watching for cases!
You have to learn to relax, Jimmy, lad.
I am certainly. I've often thought of Muppy here as about the cutest little fellow around.
Fraggle is most assuredly the best of all possible creatures.
Yep. But remember, he who laughs last, laughs last, laughs last.
No harm will come to you here. My name is Michael, and you are in heaven.
Elaine, now come on, try it.
Well, okay, if you say so. How was that, TC?
Saturday mornings just got a whole lot better on ACT and The Voice.
ACT and The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. We are talking about the causes of type 2 diabetes, but we are not just talking about the external causes. I'm trying to explain to you today what is called the ominous octet, the 8 pathophysiological factors that go into causing type 2 diabetes. And we talked about the pancreas, the beta cells deteriorating. And let me say, by the time you diagnose diabetes, some experts will tell you that you have lost 70 to 80% of the secretory function of the beta cell. And that's why the ways in which we are treating diabetes is changing. We talked about the brain, which may have surprised some of you. Diabetics don't choose to overeat sometimes. It's because the appetite-seeking centers are being changed. And then I introduced the term insulin resistance. Now, before we go further into the ominous octet, let me just start talking about some of the drugs. So metformin or glucophage, it's the number one, it's the first-line drug in treating type 2 diabetes. Now, there's a lot of bad press about metformin, a lot of misunderstandings about metformin, and glucophage is the original product, but metformin is the basic drug. Metformin does not act on the pancreas itself. Metformin acts on the liver. And I'll come to that point where we show that the liver is also part of the ominous octet. It is overproducing sugar, especially during the early hours of the morning. And metformin is very good at helping the body to deal with insulin resistance. So metformin does not act directly on the pancreas. It is acting against insulin resistance. So in other words, it's helping the receptors on the muscle, fat cells, brain cells to help those receptors respond to insulin. So insulin is like a key that fits into the receptor sites, and insulin is supposed to unlock that receptor to take sugar from the blood into the cells. Now, sugar is not bad. The problem is in diabetes, the sugar is in the wrong place. So the metformin is helping that process of insulin resistance. The second drug I just want to introduce at this point is called the sulfonylureas. And it's one of the oldest drugs we have available for type 2 diabetes. And we have a short clip on sulfonylureas. It's a little bit complex, but let's just show that clip at this point.
Sulfonylureas is a class of medications that is essential for the treatment of type 2 diabetes. It became popular after it was introduced in the year 1956 in Germany. The first sulfonylurea was tolbutamide. It had a lot of success where it decreased HbA1c readings by up to 1 to 2% on average. They were safe, cheap, and predictable. However, the incidence of hypoglycemia is still a major drawback to this class of medications. The family of sulfonylureas consists of 3 generations. An example of the first generation would be tolbutamide. Second generation is still widely used, like gliclazide and glipizide. Glimepiride is the only third generation available. So how does it work? Essentially, sulfonylureas work by increasing the secretion of insulin into the bloodstream, lowering the blood glucose level. If you want to know more about diabetes and insulin, watch my previous video. It will be linked in the description below. In a normal beta cell, the glucose enters the cell through GLOT2 channel, which would lead to a cascade of reactions resulting in the closing of the ATP-sensitive potassium channel. The latter step would lead to a depolarization of the cell. This depolarization opens up voltage-gated calcium channels. The rise in intracellular calcium eventually leads to the secretion of insulin. However, in a type 2 diabetic patient, the ATP-sensitive potassium channel is not as sensitive as the normal one. Thus, it inconsistently stays open. This malfunction results in preventing depolarization of beta cells. The main mechanism of action of sulfonylureas is to close potassium channels and restore the natural secretion of insulin into the bloodstream. One of the most popular uses of sulfonylurea medications is to combine them with the metformin, which is the first-line treatment of type 2 diabetes. A study showed a decrease of HbA1c up to 0.5% for the combination of sulfonylurea with metformin versus metformin with a placebo.
Right, so we talked about metformin, sulfonylureas. Now, I just want to correct one thing. When the speaker on that clip was talking about first, second, and third generation sulfonylureas, he was saying that there's only one glimepiride or Amaryl, as it's known in Trinidad. But actually, there's a drug called diamicron MR, which actually is one of the most popular sulfonylureas here in Trinidad, but it's not available in America. So that's why it's an American clip, although a foreign sounding speaker. So we have first, second, and third generation. Now, the problem we have with the sulfonylureas is that it has a propensity for hypoglycemic episodes. Therefore, it tends to drop, it can drop your blood sugars too low. And especially insulin in combination with sulfonylureas, which we have to do very often, gives you a higher risk of hypoglycemic events. And remember what I said a few minutes ago, by the time you diagnose diabetes, you've already lost about 80% of the secretory capacity of the beta cells. Therefore, if you're using sulfonylureas and metformin alone, it will eventually fail, because the longer someone has diabetes, the less beta cell function you have. And if you don't have beta cell function, you can flog the dead horse how much you want, the blood sugars will stay high. Now, the sad reality is this. On the government service, all we have in terms of oral drugs for diabetes is metformin and sulfonylureas. Now, I would say to the Minister of Health and the Ministry of Health, it is very short-sighted to have just 2 oral hypoglycemic drugs, because you're saying that some of the newer drugs are expensive, which they are, but when we learn about type 2 diabetes, and that's why at the level of the Ministry of Health, if we have people who understand the pathophysiology of type 2 diabetes, which, by the way, is over 95% of the people with diabetes, you will understand if you invest early on, you will prevent diabetic eye disease, you will prevent amputations, you will prevent dialysis, patients needing dialysis, you will prevent heart attacks, you will prevent strokes. Now, I'm very strong on this, so I'm making a request again to our dear Minister of Health and his advisors, those who are medically, I know our Minister of Health is a former pharmacist, but also those who surround him, the chief medical officer, etc., and the formulary committee. You need to educate yourself about the new diabetic drugs that are available, because you will understand that treating diabetes with metformin and diamicron MR or metformin and glycoside, which is on CDAP, is doing our patients a disservice, because they need the newer drugs. And internationally, we are understanding that the newer drugs is giving so much enormous benefits that we are cutting patients short of all these benefits of the new drugs. So unfortunately, on the government service, we have just metformin, sulfonylureas, and we have insulin. And even now, in the wisdom of the formulary committee, they have removed the basal insulins. So we have just Humulin N, R7030, which are the older type insulins. And the argument is that they reduce the blood sugars just as good as Lantus, etc. But again, that's a lack of knowledge and a lack of appreciation in how we treat diabetes, because if people are really studying type 2 diabetes, you'll understand that the basal insulins and the analogs reduce the incidence of hypoglycemia, and they give a more even balance to the glycemic control over 24 hours rather than the up and down lows and highs. So it's not just getting an A1C, it's how you get there is important. Now, I want to go on to the second clip that we have. I think we may just have time before we go to our second break. If we come back to the ominous octet, that was slide 9, you will see that the bowel, so we're going right around, back up the circle. I'll forget about the kidneys and the liver. You go to the last organ, which is the GI tract. This is where this new class of drugs called the DPP-4 inhibitors or the GLP-1 agonists come in. So we're just going to come off that slide. Josh, I think we may have time for the second clip. If we do, it's a nice clip. Let's just bring up the second clip on this new class of drugs called the DPP-4 inhibitors.
Hi, I'm Mike. I was diagnosed with type 2 diabetes, a chronic disease as we know. Since then, it has become increasingly difficult to keep the glucose levels in my blood stable, in spite of my medications. However, without effective control, diabetes can have severe long-term consequences, like eye disease, kidney impairment, and nerve damage. Even an increased likelihood of heart disease and stroke, just to name some of the most important complications. I immediately changed my diet and exercise habits and was started on oral anti-diabetic therapy with metformin. But that didn't bring down my high glucose levels sufficiently. My doctor intensified my therapy, successively adding a range of different traditional oral medications like sulfonylureas, alpha-glucosidase inhibitors, and TZDs. With my busy life, this was often a challenge, as some needed to be taken multiple times a day. Others upset my stomach. I needed to visit my doctor often to have the dose adjusted, and switching to injections was out of the question for me. As if this were not enough, some of the medications made me gain weight. I don't want to remember that one event where, without any warning, I suddenly fell unconscious when my blood sugar went too low, a hypoglycemic episode. And I know my doctor is doing his best to find the right treatment for me. My doctor told me that the modern approach to managing diabetes is to not only normalize blood glucose levels, but more importantly, to keep them as close to normal as possible while avoiding harmful effects to the body. How? Well, my friend here can explain that a bit better. Professor. Professor, are you there?
Oh. Hello, Mike. Here I am. Now you just sit back while I take over from here. DPP-4 inhibitors are a newer class of oral anti-diabetics, which have important advantages over the traditional treatments. Why? Well, here's what happens in Mike's body. When the tablet enters the stomach, the process begins. The DPP-4 inhibitor is rapidly absorbed into the bloodstream. In the gut, two incretin hormones, GLP-1 and GIP, are secreted in a glucose-dependent manner. The DPP-4 enzyme rapidly breaks down the naturally occurring incretin hormones, like GLP-1 shown here. But when the DPP-4 inhibitor binds at the active site of the enzyme, DPP-4 activity is stopped. Incretins are not broken down, so naturally occurring levels are prolonged, and they can contribute to their role in keeping blood glucose levels stable. So, in summary, DPP-4 inhibitors improve glucose control. By inhibiting incretin breakdown, they stimulate the right amount of insulin secretion at the right time and suppress glucagon's release, thereby reducing glucose release by the liver. That explains how they work, but you will also want to know why they are effective and safe for patients like you. Importantly, as the majority of DPP-4 enzyme is effectively and continuously inhibited, blood glucose levels not only decrease, but are kept stable during long-term treatment. Mike, in your case, we need to be especially careful about what you take because of the kidney problem we detected last time you were screened. Some of the anti-diabetic drugs are either no longer suitable or have to be dose adjusted based on additional monitoring of your kidney function.
I have high expectations of this newer class of drugs called,
Dipeptidyl peptidase 4, or for short, DPP-4 inhibitors.
Oh, thanks. Well, it sounds very promising. Something effective, tolerable, easy to take, with many long-term benefits. I look forward to future advances in this field. I'll keep you posted. Until then, goodbye, and I wish you the best of health.
Well, I think that was a very nice clip. Now, you notice the gentleman with type 2 diabetes, you notice his stomach, right? That's called abdominal adiposity, abdominal fat. And unfortunately, a lot of people in our population, we don't like to use the word fat, so I like to use the big word, abdominal adiposity. And I sometimes just tap people slightly on the stomach. I myself have, in the past, been fighting with that. I've lost a little bit due to various reasons, which were not all good. I'll come back to that on the next program we're doing. But losing fat around the tummy is extremely important. But notice that patient was trying his best. He was exercising. He was put on metformin. He was put on sulfonylureas, other drugs, something called alpha-glucosidase inhibitors, acarbose, and it wasn't working. And then he was put on the DPP-4 inhibitors, dipeptidyl peptidase 4 inhibitors. And basically, this drug acts by blocking the breakdown of something called glucagon-like peptide, and the GLP-1 enzyme acts on the pancreas. So as you eat, this enzyme is released, but in diabetics, you lose that secretion. So this drug is blocking the breakdown of GLP, and it's helping to prime the pancreas. It's protecting the beta cells, but it's also turning off the sugar that's coming from the liver. It is decreasing glucagon levels. I think we have to go to our second break now. We'll go to our second break. Remember, the number you can call is 482-4269 or 653-8249 during the week if you need more information about these programs, and we can try and return your calls. So we'll go to our second break and then return to our final session of Your Health, Your Choice.
You're watching ACTN, The Voice. ACTN The Voice, your family-friendly station.
Kids Classic TV on ACTN The Voice.
You ding-dong! You're supposed to be watching for cases!
You have to learn to relax, Jimmy, right?
Certainly. I've often thought of Muppy here as about the cutest little fellow around.
The Fraggle is most assuredly the best of all possible creatures.
Yep. But remember, he who laughs last, laughs last, laughs last.
No harm will come to you here. My name is Michael, and you are in heaven.
Elaine, now come on, try it. Well, okay, if you say so.
How is that, TC?
Saturday mornings just got a whole lot better on ACTN The Voice.
ACTN The Voice, your family-friendly station.
Welcome back to Your Health, Your Choice. I want to remind you that we're doing what you're looking at is a pre-recorded program, so you're not able to call in with your live calls. I know a lot of you like to do that, but maybe in the future we'll return to the live programs on Wednesday nights, but it's also played on Thursdays at 1 p.m. and Sunday nights at 7 p.m. The numbers I mentioned will come up on the screen as well. You can call during the week on 482-4269 or 653-8249. There's also an email address you can send your questions. Now, we've been talking about the causes of type 2 diabetes, and I've been talking about the ominous octet. And the last session, the last few minutes, we talked about the dipeptidyl peptidase inhibitors, DPP4 inhibitors. And some of those drugs are like Januvia, Galvus, Tradjenta, Combiglide. So we have 4 or 5 of those drugs on the market. As I said in the previous session, we unfortunately on the government service have none of these drugs available. And if you looked at that clip, and I would advise our formulary committee members, our Minister of Health, maybe to look at that clip or to do some more reading, because we need these drugs in the government service. Because what you understand is that when you have just metformin and diamicron or glycoside, you're only treating 2 or 3 of the pathophysiological defects in type 2 diabetes. Now, over 95% of our diabetic patients are type 2 diabetics. So we are doing them a disservice, and in fact, we are doing the health economy a disservice by not having these drugs available, because you're trying to save money up front, which is very short view, and you're then ending up with people on dialysis, heart attacks, and you're spending thousands of dollars trying to deal with the complications of diabetes. Can I say that we need to pump money into the primary healthcare setting where most of the diabetes care takes place? We now have community diabetologists, community specialists in diabetes, where we can handle most of our diabetics in the community, in the health centers in the Southwest. We have pioneered the community diabetic specialist clinics, and we are seeing a lot of the complicated patients, and we are able to treat them effectively with the limited drugs that we have available. So we dealt with 4 or 5, and I'm going to come back to that slide 9 now, as we are in our last session. We talked about the pancreas. We talked about the brain going in a counterclockwise direction. We talked about the fact that the muscle and the fat cells, that's the third organ that is shown in a clockwise direction, being resistant to the uptake of diabetes. When you go right around, we talked about the gut. We never realized that the gut had a part to play in diabetes metabolism. But if you come back to the 4th organ, the kidney, now this is now the latest organ that we are recognizing has a part to play in type 2 diabetes. So we can just come off the screen of that slide. So we now understand that the kidneys have a part to play in keeping blood sugars high in type 2 diabetes. What happens is that the kidneys have a threshold. When your sugar rises above a certain level, above 180 milligrams per deciliter, you're supposed to spill sugar in the urine. And so in the old days, we used to test the urine for sugar to diagnose diabetes. We no longer do that, because what we realized about 10 years ago is that the threshold for excretion of sugar in the urine in diabetics is lifted up. So you are running a much higher blood sugar, and the threshold for spilling sugar is no longer the 180. So you could be running a blood sugar of 250, and we're talking about that organ at the bottom half of the diagram, the kidneys. So you could be running a high blood sugar, and there's no sugar in the urine. So what researchers recognized is that there was a receptor site called the sodium glucose cotransporter, and there's the cotransporter 1 and 2, but the SGLT2 receptor is responsible for reabsorbing about 90% of the sugar that is being excreted. So now there's a new class of drugs that we've been waiting for a number of years, has been in the US for some time, and England and Europe, the SGLT2 inhibitors. And we now finally have 3 in that new class. One is called Jardiance, another one is called Invokana, another one called Forxiga. And I already have many of my patients on these drugs, and we are seeing some dramatic improvements. Patients that we struggled with for years to get under control, we are now getting them under better control. So we have our final clip tonight. We're going to show a little clip on how the SGLT2 inhibitors work. So let's go to our final clip. So that gives you a very nice overview on this latest class of drugs that we have available called the SGLT2 inhibitors. And I like the last frame of that clip where it showed options, options, options. In other words, treating type 2 diabetes is much more complex than saying one cap fits all. And the patient that sits before you, the art of doing medicine and the art of practicing medicine, as we call it, is looking at that patient. Is that patient overweight? Is that patient carrying a lot of abdominal fat? Is the patient losing weight? How long the patient has had diabetes? There are some clips I was going to show you. In fact, I will just show you one slide 13. Slide 13 And what this shows you is that if that patient, the approach to the management of hyperglycemia, which is high blood sugars, the A1C is that blood test that tells you the 3-month average. You can see that for different patients, you may have different goals. So if that patient has a high risk of hypoglycemia, you want to be less stringent. That's on the right-hand side. And more stringent if it's a young patient with a low risk of hypoglycemia. Now, I'll just come off that slide. There were several slides like that I was going to show you. If the patient has cardiovascular disease, has had heart attacks, if the patient has kidney failure, your goal for the blood sugar management and the blood sugar control varies. So the fact that, we talk about an A1C of 7% or less, if I have an elderly patient, 75 years old, who is very unstable on their feet and is at risk of falling over, I would be happy with an A1C of 7.5 or even 8%. Now, that might surprise some of you because you've been trained to think that there's one goal for everyone. That's why when people tell you that one particular product can cure diabetes, can cure heart disease, can cure cancer, can cure acid reflux, that's absolute nonsense. Absolute nonsense. And what I want to encourage you to think about when you look at different medical programs or some so-called medical programs, look carefully, listen carefully what is being said and see if any science is being mentioned rather than someone coming and giving a testimony, as they call it. A testimony says nothing about the efficacy of a drug because there are so many different factors interplaying. Now, I didn't have time today to talk about 2 other classes of drugs. So it's already becoming very complex what I've mentioned, but we have the thiazolidinediones. Now, those are Avandia and Actos. Avandia was taken off the market a few years ago, but it's back on the market. Actos is still available, has always been available. I don't think either of them are available in Trinidad, but particularly Actos is a very good drug for people with a fatty liver. A lot of our diabetics have a fatty liver and they have insulin resistance, and Actos is a very good drug for those patients. So I would ask the company, I think Lilly, that had Actos in Trinidad at one stage, to bring it back in because a lot of our patients have insulin resistance and they would do very well on Actos. And then the last class of drugs I didn't mention, and remember, we have not even talked about insulin today because I talked about insulin on the last program. It's the GLP-1 agonist. Now, the GLP-1 agonist acts on the same axis as the DPP-4 inhibitors, but it's an injection. We have one in that class, Byetta, which is not so popular right now, but we are waiting on one called Victoza, liraglutide. The company that does that, Novo Nordisk, is about to launch Victoza or liraglutide. It's a once-a-day injection. And then we have, if you look at cable, you would see that there's a drug called Trulicity. And Trulicity is a once-a-week injection. So imagine, we now have a drug that you can take once a week for diabetes. And we're waiting for that drug to hit the market. I don't know when it will be coming into our markets here in Trinidad. So what we have been showing you here today is the pathophysiology of type 2 diabetes. And again, I know I'm harping on this. I want to say to the government service and the Minister of Health and his advisors, the Chief Medical Officer and the Formulary Committee, really, you need to look at some of these new classes because the SGLT2 inhibitors, if you looked at what it did, it's helping, it's acting in a completely new way. It's encouraging increased excretion of insulin, of sugar in the urine, so people can lose weight as a result of this. It's complementing drugs like metformin, complementing drugs like the DPP-4 inhibitors, Januvia, Galvus, Combiglide, Tradjenta, and it can also complement insulin therapy very well because of the weight loss, and the weight is working, and you can actually decrease insulin levels. So I'm excited about this new class of drugs. It's a little bit expensive, but we can use it very, very effectively in combination with other drugs. So you have a number of options ahead for you as a type 2 diabetic. You don't just have to be despondent because you're on metformin and sulfonylureas. You have a number of new drugs, so you need to ask your doctors. Even if you're under the government service, they may not have it available, but if you can afford to buy it and maybe take it once every other day or so, it will cut down the cost and help in the control of type 2 diabetes. So what I've tried to present to you today is called the ominous octet in the treatment of type 2 diabetes. The telephone numbers, as I said, was 482-4269 or 653-8249. You can ring those numbers during the week, and we can give you more information at our center, the Anapausis Center. We are based in Vista Bella, in just near Victoria Nursing Home. But I'm going to take the final 2 minutes to put on my pastoral hat. The Trinidad and Tobago Anapausis Center is a church that we lead. We are based in Koke. You can see us just off the bypass. And I want to leave you with a thought. And that same number, 482-4269, you can ring us for pastoral advice and for counseling, etc. We often face what we call giants in our life. And there's a famous story in 1 Samuel chapter 17 of Goliath, the giant of the Philistines, facing the armies of Israel. And none of the mighty soldiers were willing to go out and face Goliath. But little David, he wasn't King David as yet. Little David was as a shepherd, heard about this, and he ran to the battle, and he faced the giant in his life. And he was able to kill that giant. And he said, I come to you not in my own strength, but in the strength of the God of Israel, or my God, the God that I know. I want to say to you as I end tonight, some of you are facing giants of sicknesses, giants of unemployment, giants of financial struggles, giants of depression, giants of relationship problems. Your marriage is under severe stress. It might even be abuse. And these giants continue to shout at you. You're trying to move on in your life, and those giants continue to shout at you. I want to encourage you to discover a relationship with God through Jesus Christ. Come to the foot of the cross. Learn about a relationship with God. He can give you the strength to overcome every single giant in your life. 482-4269 is the number to call for more information about the medical program as well as the pastoral advice that we have given. Thank you for joining us tonight on Your Health, Your Choice. So if you're looking at it during the day, thank you for joining us. We will be back with a program next week. Hopefully, I will have Dr. Yajish Singh, a laparoscopic surgeon, with me talking about colon cancer and other surgical problems. Thank you for joining us. I'm Dr. Claude Khan.